and signet ring cell plus mucinous adenocarcinoma, they all comprise as undifferentiated type, and remaining all histologies will be differentiated, that are papillary adeno, tubular adeno. Okay, so undifferentiated will be poorly differentiated signet ring cell and mucinous adeno. Now, ulcerated or not, histological predominance and intratumoral ulcerative findings. So predominance, whatever type will be predominant, we will tell like that only. But we have to mention both. Like if there is tubular adenocarcinoma, type 2 is more, then we will mention it like this. 2 is more than 1. And diagnosis of ulcerative lesion 1 is principally made based on the histological evidence of ulcerative findings. And if biopsy was taken previously, we can confuse it with the ulceration because there will be fibrosis. So it becomes hard sometimes to differentiate whether this fibrosis is due to the disease-related ulcer or biopsy-related scar. So if we can clinically differentiate it, then it's okay. If cannot discriminate, then we have to depict it as UL1, ulcerative lesion type 1. In biopsy-derived scar, fibrosis is restricted to small area just beneath the muscularis mucosa because we target the mucosa mostly. Then there are indications for endoscopic resection. So there are 3 types of indications: absolute, expanded, and relative. So what are absolute indications? The conditions in which chances of lymph node mets are very less, like less than 1%. The resection will be as curative as the surgery. So this will be absolute indication. We can read it like that. Defined as a tumor in which the possibility of harboring lymph node metastasis is less than 1%. For this population, endoscopic resection is expected to have therapeutic equivalence to the surgical resection. Then what is expanded indication? Tumor for which sufficient evidence of long-term outcome after endoscopic resection are lacking, although the possibility of harboring the lymph node metastasis is less than 1%. So absolute, we know, we have evidence also that the lymph node metastasis will be less than 1%. Hence, local resection will be equivalent for the
surgical resection
to the surgery. That is gastrectomy with lymph node dissection. If we do, it will be giving equivalent results. So definitely we will do the local excision only. Then expanded indication, we know that the chances are low, but there is no long-term evidence. Then what are relative indications? Relative indications are as such not indications for endoscopic resection, but suppose the patient is poor, GC poor due to heart disease or something, whatever. If patient is not fit for big surgeries, definitive surgery, we can go and do the endoscopic resection. That will be relative indications. So what are the principles for indication? Endoscopic resection is considered for tumors that have a very low possibility of lymph node mets and are suitable for en bloc resection. And what is that very low possibility? Less than 1%. Indications, absolute indication for EMR and ESD. So differentiated type adeno without ulcerative finding, in which depth of invasion is clinically diagnosed as T1A and diameter is less than or equal to 2 cm. So that will be absolute indication for EMR or ESD. Then what are the absolute indications for ESD? That is for the dissection only, not for EMR. As in EMR, we know that we are going to resect the mucosa only. So very limited tumors will be the absolute indications that we can understand by the explained criteria. It should be ulcerative 0, differentiated, and less than or equal to 2 centimeters. T1A. This will be only indication for EMR. Then what are the indications for endoscopic dissection, that is ESD? So we can understand from this flow chart. First we will see that all lesions are T1A or a dissection as well. Then in that we will see whether it is ulcerated or not. So if it is not ulcerated, then we will see the type of differentiation, whether it is differentiated or undifferentiated. If it is differentiated, then diameter, even if it is more than 2 centimeter, we can go for ESD. If it is undifferentiated and diameter is less than or equal to 2 centimeter, we can go for ESD. Likewise, if it is ulcerated and differentiated, then we can do ESD up to 3 centimeters. And if it is ulcerated as well as undifferentiated, then we cannot do ESD. We will straight away do gastrectomy with lymph node dissection. Okay. So we will revise once. T1A, if it is not ulcerated, then in differentiated more than 2 centimeter, we can also do ESD, or undifferentiated less than 2 or equal to 2 centimeter. If it is ulcerated, then only in differentiated type we can do ESD up to 3 centimeters. And if it is ulcerated and undifferentiated, there is no indication of ESD or endoscopic resection. Straight away we will do gastrectomy. Then expanded indications. So if locally recurrent lesions in which the depth of invasion is clinically diagnosed as T1A, after initial endoscopic resection, it comes as EQRA C1, then we can again do ESD. We will read it further. This is expanded indication. And as we discussed, what is relative indication? Standard therapy is surgical resection for tumors that do not fulfill the absolute or expanded indications. But we will do the local resection only in view of maybe patient is old age or there are severe comorbidities. Then after the resection, we describe the curability of the endoscopic resection. That has 3 classes: endoscopic curability, curability A, B, and C. So evaluation of curability, 2 factors should be considered for curability assessment: completeness of the primary tumor removal and possibility of lymph node mets. So for endoscopic resection, as we all know, if it is less than 1%, then only it is indicated. Then we will see the completeness of the resection. So endoscopic curability, what is endoscopic curability A? That is EQRA A. So the resection is classified EQRA A when all of the following conditions are fulfilled. That is most favorable condition. Tumor should be UL, not ulcerated, any tumor size but differentiated. If it is undifferentiated, then it should be less than or equal to 2 centimeter. That we have to remember. Even if it is undifferentiated and less than or equal to 2 centimeter, and PT1A, all the margins are negative. Horizontal margins we write as HM 01 and negative vertical margin. So all the favorable things should be there. No lymphovascular infiltration. So the tumor is PT1A and all favorable all margins negative, no lymphovascular invasion. Then further, if it is differentiated, as we already discussed it, if it is differentiated, then any size. And if it is undifferentiated, then less than 2 centimeters. We discussed same thing in indications now. This. So if it is dissected completely with negative margins, it will be EQRA A. Now, if the lesion is ulcerated, further one thing more we will see. If it is undifferentiated component and more than 2 centimeter, we will straight away write it EQRA C2. So this is one thing that is included in C2. We have to remember undifferentiated more than 2 centimeter is C2. Then if the ulceration is there and rest all findings are like that. So in ulceration also we saw that thing. If it is ulcerated, differentiated less than or equal to 3 centimeters and resected with all negative margins without any lymphovascular invasion, then this will also be EQRA. All our indications, if resected with negative margins and no poor prognostic factor, they all will be EQRA. Okay. Then endoscopic curability type B. So what is type B? As endoscopic curability B for T1B cancers in T1B. So T1A we have already seen. If the tumor is T1B and the depth of invasion is less than 500 micrometer from the muscularis mucosa in differentiated type 1, in differentiated less than 500 micrometer and all other prognostic factors are in favor, then we will write it as type B. However, if the undifferentiated component is included in the portion of submucosal invasion, the endoscopic curability will be directly C2. So we have seen two things when we will write C2
For B.
if undifferentiated is more than 2 centimeter and if it is infiltrating the submucosa. These are two conditions. We will straight away write it C2. Then comes the definitions for endoscopic curability type C. So there are two types, C1 and C2. C1 is basically when we remove the tumor piecemeal or some margin is positive. Say horizontal margin is positive or vertical margin is positive, then we will say it C1. And what will we say C2? We have already discussed. This is C2. Okay. Then what are the meaning of all these? So after endoscopic curability A and B, we will keep the patient on follow-up on. And how we will follow up with the help of endoscopy, abdominal ultrasound or CT scan. However, we can test the patient for H. pylori infection because if it is positive, it should be eradicated since the risk of metachronous gastric cancer is there on long-lasting, long-term follow-up. So type A and B, we will screen for the H. pylori. H. pylori, if it is positive, we will eradicate it. What if it is type C1? C1 means margin positive. So if margin is positive, we have these options. Repeat ESD, surgical resection, close observation, expecting a burn effect in the initial ESD, and endoscopic coagulation using laser or argon plasma coagulator. Because focal margin is only positive, so we have all these options. When the lesion is differentiated type less than or equal to 3 centimeter and UL positive, PT1 AM or SM1. The size of the residual, like if it margin is positive on the final HPR, we have to see the residual mucosal lesion also. We will do again endoscopy and see the residual tumor. If sum of both these, that size in the HPR and the remaining mucosal lesion, if the sum is more than 3 centimeter, we will go for gastrectomy with lymph node dissection. Okay. In addition, for patients with a positive horizontal margin within the portion of submucosal invasion, for those who underwent piecemeal resection and having submucosal invasion, we will do gastrectomy. So for every C2, we have to do gastrectomy. And other than C2, if there is C1 and we find that remaining and the size in the HPR plus the remaining mucosa is more than 3 centimeter, then we will do gastrectomy. If we see that it is infiltrating the submucosa, then we will do gastrectomy. So these all are indications of gastrectomy based on this. This is a flow chart. The things we have discussed already.
नाइस एक बार फ्लो चार्ट दिखाओ उसका स्क्रीनशॉट लेना फ्लो चार्ट का स्क्रीनशॉट लेना है
स्क्रीनशॉट ले लो पूरा आर्टिकल ले लो
आर्टिकल तो ठीक है ठीक है
तो इतना था एंडोस्कोपिक डिसेक्शन बाकी सब ये अनरिसेक्टेबल में कीमो एंड ऑल अगर आप लोग बोलेंगे तो नेक्स्ट टाइम बताता हूँ नहीं तो ज्यादा इंटरेस्टिंग नहीं लग रहा ओके दैट्स इट
क्वेश्चन क्या आया है देखा है क्या आपने
ये तो आर्टिकल डिस्कस करना था जस्ट लाइक क्वेश्चन तो अपने उसमें आया था एंट्रेंस में आया था एक ईक्यूरा पे एंडोस्कोपिक डिसेक्शन पे ओके, यही है आज के लिए।